In this brief period of time, my name is Dr. Peter Mccullough. I'm an internist and cardiologist in Dallas, Texas, and I've been very involved in the pandemic response. I've been honored to be involved in publications, over 45 publications in COVID-19, as well as been honored to have U.S. Senate and State Senate testimonies. In the next few minutes, what I'll do is go over this protocol called sequenced multi-drug therapy for COVID-19. And I'll just spend the time on this one slide since there's so much information here. What is suggested based on the precautionary principle, meaning that this is a mass casualty situation, we can't wait for large randomized trials, and we can't wait for society guidelines. We must act now to save lives, to reduce hospitalization and death. What we know is that this disease is amenable to risk stratification, and not all individuals require treatment. Approximately 25% of adults would require treatment according to this protocol. And what we suggest is that when COVID-19 illness is confirmed at the top of the white box here, that this is the one time where quarantine is needed at home. The only time a lockdown or quarantine is needed in someone who's sick, well, people don't need to stay at home because they don't have the virus. Only those who are sick need to stay at home. We recommend povidone iodine or betadine, very dilute solution with nasal washes twice a day. For prophylaxis, it can be actually up to 4 times a day for active treatment. Because the Delta virus has such a large viral load, about 251 to 1,000 times more than other variants, we need to actually start decontaminating the nose and the mouth. If there's iodine sensitivity, we can use dilute hydrogen peroxide, dilute sodium hypochlorite, or even forms of mouthwashes. We should do contact tracing, contagion control, and ventilate the house, get fresh air, get people outside. When individuals are ill inside with no air ventilation, there's just re-inoculation of the virus in theory. If age under 50 and healthy, we recommend a nutraceutical bundle with zinc sulfate, vitamin D3, vitamin C, quercetin, and then just watchful waiting in complete self-quarantine. Our U.S. CDC says 10 days from the start of illness and 48 hours without any fever can return to work. So this can be a very short quarantine. If a young person, if symptoms worsen, then they should move over to the treatment category. Age over 50 or with multiple medical problems should also be in this middle treatment category. And in the United States, what we do, first line is we use the emergency use authorization monoclonal antibodies, and our current preparation is 2 monoclonal antibodies in a single infusion by Regeneron, and that's caricivimab and indimavab infusion. It takes about an hour. We like to do this as soon as possible in the illness, and then this takes 1 hour of observation and patients go home. I had 2 elderly patients yesterday get this infusion. It's available. Doctors and hospitals should offer it. If it's available in other countries, these types of infusions or others, each day that goes by, we lose an opportunity to reduce mortality. So this should be done, in my view, very early on. If the monoclonal antibody infusion is done, we can actually skip the anti-infective box here. But if we can't get the antibody infusion, we need at least 2 drugs to try to contain viral replication. So we can use hydroxychloroquine as frequently done in Italy. And there are over 250 supportive studies. The overall interpretation of the literature is that earlier starting hydroxychloroquine, the better. There's only 5 randomized trials that don't show benefit to hydroxychloroquine. Only 2 of those are placebo-controlled trials. These are very small, underpowered trials, inconclusive, and they're done very late in the hospital. The vast majority of the 250 studies with hydroxychloroquine are positive, including the outpatient clinical trials when assembled into a meta-analysis. Ivermectin can be used in a wide range of doses, weight-based dosing, 200, 400, 600 micrograms per kilogram, given for a series of doses as little as 1 to 5 doses or more. And ivermectin is supported by over 60 supportive studies and over 30 randomized trials. Uniquely with ivermectin, the general read on the data is that trials are both positive for inpatient and outpatient utilization. In Russia, Japan, other countries in Eastern Asia, favipiravir, an oral polymerase inhibitor, can be used in a loading dose and then in a maintenance dose over time. We combine these drugs with azithromycin or doxycycline because whether it's a macrolide or tetracycline antibiotic, they work intracellularly and have some additive effect. In addition, we know that there's about a 2 to 3% overlap with chlamydia pneumonia and mycoplasma pneumonia, and in this circumstance, we need coverage for these organisms. Additionally, there is a low but real rate of bacterial superinfection in the sinuses and the bronchi, and this cuts down on secondary sinusitis and bronchitis. So we believe the antibiotics play a role. We recommend inhaled budesonide now, and that can be a Pulmicort inhaler in the United States or by nebulization, starting on day 1. When respiratory symptoms develop, or on day 5, using prednisone or dexamethasone or hydrocortisone is very well supported in a meta-analysis of over a dozen studies. And it doesn't matter which steroid is used. Dexamethasone is probably not an ideal choice. And then colchicine, supported by the Col-Corona trial, is given twice a day for 3 days and then for 30 days following that trial. The Col-Corona trial was supported with over 4,000 patients, double-blind, placebo-controlled randomized trials. Those who had confirmed positive PCR for COVID-19 enjoyed a reduction in hospitalization and death. Budesonide is supported by 2 randomized trials in COVID-19 for outpatient use, has a dramatic reduction in hospitalization and death. We recommend now that aspirin, 325 milligrams a day, is given for all individuals to have some attenuation in the risk for thrombosis. And this is supported by data from UCLA by Gupta and colleagues that shows that there's a marked upregulation of thromboxane A2 and thromboxane B2, and the best way to inhibit that is with the use of aspirin, full dose. And then low molecular weight heparin, we can use enoxaparin outside the United States, a variety of other dalteparin and frexaparin can be used, or we can use novel oral anticoagulants, apixaban, rivaroxaban, dabigatran, edoxaban, all used in standard doses. Now, the reason being is because there's an early phase of viral replication, there's a middle phase of cytokine storm or inflammation, and then the fatal sequence is microthrombosis. When the oxygen saturations are going low in the human body, all the autopsy data suggests that the problem is microthrombosis. The problem is not viral replication or even cytokine storm at that instance. So we need to use aspirin and anticoagulants. The single greatest mistake I see is when oxygen saturations are low, people are reaching for antivirals like remdesivir. That doesn't make any sense at all. Remdesivir doesn't have any influence on microthrombosis, but aspirin and full-dose anticoagulation do. And these are supported by inpatient studies. The outpatient randomized trials of anticoagulants are still underway. So what I'm telling you is I think the approach and other protocols that exist are terrific, and they tend to be derivatives of these concepts. There are additional drugs that can be used. Certainly fluvoxamine can be added in, oral anti-androgens can be added in, oral famotidine. It simply boils down to a burden of pills that can be taken. But as long as there's something that addresses viral replication, something that addresses cytokine storm, and something that addresses microthrombosis in a sequenced multi-drug combination or even in a consolidated combination, as I'm showing here, this is what really makes the difference in COVID-19. I'm talking about starting on day 1 in highest risk patients. Unfortunately, those who are hospitalized, virtually every one of them has received no outpatient care whatsoever. And the only way to prevent a hospitalization is to do something before the hospitalization. And this is whether or not someone has received a vaccine. We know that patients who have received the vaccine are also being hospitalized, and unfortunately some are dying. And so we should not discriminate based on who's received a vaccine or not. In my view, these treatments should be given to patients with COVID-19, young people who have severe symptoms, or those who are over age 50, even without severe symptoms, because we know that the infection is going to get worse over time. That's the reason why it's called sudden acute respiratory distress syndrome, because it will suddenly deteriorate. In those over age 50, we should use the precautionary principle and start empiric treatment, even if the symptoms are very mild. Notice that I indicate on the right-hand part of the slide that the need for room air, pulse oximetry at home, which is reasonable in higher risk individuals, and then to constantly reevaluate by telemedicine or even making in-person visits. For the healthcare providers who have already had documented COVID-19, they can't get it a second time. So there's no problem in seeing patients face-to-face. There's no problem in examining patients. One can do that without a mask or any other type of personal protective equipment because one can't get COVID-19 multiple times. And so you don't have to be fearful. Once you've had COVID-19, you have robust, complete, and durable immunity. One should not do that if one is relying on the vaccine alone because we know the vaccines failed against the Delta variant. In the United States, we have 99.1% Delta variant. So I don't encourage anyone who's been vaccinated and they're relying on vaccine alone to protect them because it looks like it won't. But natural immunity, that's been well supported by data from the Cleveland Clinic, by Shretha and colleagues. Healthcare workers can go into the workplace and be free of any risk of infection provided they've had previous COVID-19. Even without a vaccine, the vaccine can't improve upon the natural immunity. So I'll stop here and we'll keep the program on time. It looks like a terrific conference. I'm in the hospital in the clinic right now, so I'm going to start to see patients. Let me know if you want me to answer any questions now, or we'll let the program move on and then into a panel. Thank you.